viewers and dear friends, making the first move, revolutionizing the diabetes management with insulin deglutec aspart. The diabetes prevalence is increasing worldwide in a tsunami proportion. In 2021, there were nearly the 53.7 crores are having the diabetes, and the projections by 2045 is about 78.3 crores. I am damn sure that we will reach this figure by 2035, maybe a 1 decade earlier also. The way the rise of the diabetes we are seeing in the world, a lot of the people are getting the type 2 diabetes even at the age of 20 plus or 15 plus also, as far as the type 2 diabetes is concerned. So type 2 diabetes is the most common type, accounting for about 90% of all the diabetes in the worldwide. So this is the burden of the diabetes in India. By 2023, we are having about 10.1 crores, and nearly the 13.6 crores are the pre-diabetics. And the conversion from the pre-diabetes to the diabetes is a very, very high in Indian population, to the tune of about 60 to 80%. Whereas in the Western countries, the conversion of the pre-diabetes to the diabetes is just 14 to 18%. What about the burden of the uncontrolled diabetes in India? Why we are worrying about the diabetes? Because it is the most asymptomatic disease. 80% of the people, they don't have any symptoms, but we are much worrying about the diabetes because of its complications. Maybe the microvascular complications or macrovascular complications or the infections. See here, the people with type 2 diabetes had an HbA1c of less than the 7%. Less than the 7%. Your target is only 6.5%. Some people may be the 7%. So somewhere between 6.5 to 7% we have to maintain our diabetics. But these studies say that only 19.7% in 2011. In 2019, it was 23.4%. In 2020, about the 22%. So only few people, I think less than the 20 or 24% are people getting the less than the 7%. That means 75 to 80% of our diabetics, they are not reaching the targets. So that means we are inviting the complications for them, about 80% of the population. So we have to understand the diabetes and we have to update our knowledge. So to keep all our diabetics to less than the 7%, so that to avoid the long-term complications. See, insulin is a very, very important molecule. We all know that. Big thanks to the Banting and the Best for their excellent discovery of the insulin. But unfortunately, insulin is the most underutilized drug in our Indian population. Say there are only 6 million population in India are being managed with the insulin. A lot of the people, they require insulin, but because of the several reasons, maybe the physician barriers or the patient barriers, we are not able to utilize the insulin at its maximum potential. That is the reason these such type of the classes or lectures are being organized to improve all our doctors community, to make them to use a lot of insulins in our people, for those people who require it actually. See here, the delayed insulinization. 5 out of the 10 people with uncontrolled diabetes, they delay the insulin therapy. You all know what will happen if you delay the management of the diabetes. So once we are delaying the management of the diabetes for its proper control, we are inviting the complications. So as Dr. Kada has rightly pointed out that the lifestyle diseases like diabetes, hypertension, so partly because of our not initiating the insulin at its right time. See, if you see this slide, pre-treatment and the post-treatment, if the fellows are on the 2 oral hypoglycemic agents, so the reduction of the HbA1c is just 1%. If the people are on the 3 antibiotics, 3 hyperglycemic agents or oral hypoglycemic agents, the reduction is 0.5%. If the people are on the 4 OHS, so then the reduction is 0.2%. So that shows that the more the OHS the people are getting it, the lesser the reduction of the HbA1c. So in such individuals, if you initiate the insulin therapy, so obviously the HbA1c control will be very good and the reduction will be very good, so that we can avoid the long-term complications. So successive oral hypoglycemic agents, they provide the lessening effect. See, the no more diabetes, no more insulin is a anti-hyperglycemic agent, but that has a cardioprotective, a neuroprotective, and anti-apoptotic drug. It is a big vasodilator, and the platelet inhibition will be controlled, and there will be beta cell rest and improvement in its function by initiating on insulin therapy. It is an antithrombotic agent, antioxidant agent, and anti-inflammatory agent. See, all these functions are very well needed for most of our diabetic individuals to avoid the vascular complications. So insulin is always advisable for those people who require it. And we are totally different Indian diabetic when compared to the Western diabetic, because the thin fat Indians. See, a lot of the people in the Western world, all the type 2 diabetics, 80 to 90% are the overweight. Whereas in India, most of the type 2 diabetics, they are the normal weight, or some people may be the underweight also. So this thin fat Indians, this is because of the high visceral fat. You all know that the abdominal adiposity is very, very common in our Indian population, and higher fat mass and the low muscle mass. There may be some genetical factors and low birth weight. So these are all the things say that the thin fat Indians is a definitely a unique people where we have to address the insulin deficiency here by introducing the early insulinization. So definitely we can give good life to these thin fat Indians. Higher insulin resistance on the other hand, so we are having the obesity. In fact, India is the obesity capital of the world. So all the overweight or the obese individuals will have a lot of the insulin resistance, and insulin resistance is the root cause for your metabolic syndrome. So insulin resistance is the cause for diabetes, cause for hypertension, and insulin resistance is the cause for dyslipidemia and obesity. And early decline in the beta cell mass. So we are getting the diabetes in younger age group, maybe 2 decades earlier to the Western population. So that means when the fellow is getting the type 2 diabetes in younger age group, as years goes on, the beta cell decline function will be declined, and obviously after 20 years or 30 years of the diabetic life, they almost behave like the type 1 diabetes with very, very, very little beta cells. So when a fellow gets the type 2 diabetes at 25 years of age group, I think by 45 or 50, he almost behaves like the type 1 diabetes. So he needs very high intensity insulins, maybe the basal bolus therapy also. So high risk for the diabetes complications. So in India, 40 to 50% of the type 2 diabetics, they present with the complications at the time of the diagnosis itself. So most of the times in India, the diabetes being diagnosed by the cardiologist or the neurologist or the nephrologist or the gastroenterologist or the general surgeons or even the gynecologists, etc., because they present with these complications with a particular subspecialty and they diagnose the diabetes. So to reduce the complications of the diabetes, we need euglycemia, and here also the insulin is very much needed to control the blood sugars very effectively. See, we all know that our diet is very rich with the carbohydrate. A high carbohydrate diet is a very, very common in Indian reality, more so in our Godavari districts. See, if you see the Western population and the Indian populations, we are having the postprandial glucose peaks 2 to 3 times the higher. So this is the average HbA1c in India, about the near the 8.5 to 9, and fasting blood sugar 172 and postprandial blood sugar 253. So the need for the different insulin requirements, especially higher mealtime insulin dosages. So we have to consider not only the fasting blood sugars, but also the postprandial blood sugars much higher in our Indian population to tackle this postprandial hyperglycemia. So we have the a good insulin molecules to reduce these things. Evidence from the Indian studies, high postprandial fasting and the HbA1c. If you see this slide, when the HbA1c is at 8.5 or 8.9 or the 9.2, etc., in all, whatever may be your HbA1c, the fasting is less and postprandial is much higher. So this is exactly opposite to our Western population, where the fasting hyperglycemia is much more when compared to the postprandial hyperglycemia. So at any level of our HbA1c, our Indian population, postprandial is much more than the fasting hyperglycemia. So uncontrolled glycemia in India demands timely treatment optimization with the total control. So the ground realities in India, this is the impact survey. So says that 73% of the healthcare professionals prefer the premix insulins in patients with a high carbohydrate intake. So shortcomings of the basal insulin. So already we know that the basal insulin is the best insulin to be started in all our diabetic individuals for the simple reason that you can start with 10 units of the basal insulin at the bedtime, and you can titrate the fasting blood sugars, and according to the fasting blood sugars you can up titrate or down titrate your basal insulin to reach the euglycemia. So is it really short of what we need for the Indian people with the diabetes? So the basal insulin that controls your insulin hepatic glucose production. So it reduces the fasting hyperglycemia. Whatever the postprandial hyperglycemia, which is very, very common and much higher when compared to the fasting hyperglycemia in our Indian population. So you have the premix insulins, basal insulins, and the co-formulations. So the first move can change the game, because if you control the blood sugars very effectively, obviously we can avoid the complications. So this is the first move. So insulin deglutec and aspart versus premix regimens. So this is the Research Society for the Study of the Diabetes in India. So recommendation 2022. So this is recommended as a first choice for your insulin initiation because of the less hypoglycemia, flexibility of the administration with any major meal. So when the fellow is getting the major meal of the lunch, so you can start this with before the lunch, or when the fellow's main meal is the dinner, you can start just before the dinner, and some people before the breakfast also. It's a low dose and less weight gain is noted with this combination of the insulin deglutec and the aspart. So if you compare this basal plus regimen and insulin deglutec and aspart, basal plus means you are giving the basal insulin at the bedtime. Plus means your prandial insulin before the lunch or before the dinner, which one is a main meal. So this is a complex regimen. You need the two insulins or two pens, one before the lunch or the dinner and another one at the bedtime. Whereas if you use this insulin deglutec and aspart, a combination of these drugs, a similar reduction in the HbA1c is noted here with lesser hypoglycemia and requires the lesser dose and simple to administer. So with the lower hypoglycemia, a mealtime flexibility, ease of use as a single, convenience, better quality of the life, and cost effectiveness, and of course the efficacy is also very, very important. So this product is definitely suitable all these things. See, this is an ultra long acting deglutec, that is a basal insulin, about a 70%, and the regular short acting and rapid acting was a 30%. So this short acting aspart is in the hexameric form, and the long acting deglutec is the dihexameric form. So by introducing it into the subcutaneous route, and immediately slow dissociation is seen with the basal insulin, and the rapid dissolution is seen with the insulin aspart. So this insulin aspart will take care of your prandial hyperglycemia, postprandial hyperglycemia, and this deglutec part will take care of the basal hyperglycemia. So when you compare this insulin deglutec and aspart with the glargine 100 units and the glargine 300 units, so glargine 100 any time of the day, but same time every day, because the glargine acts for about 18 to 24 hours. So you have to give it at a regular time, maybe 8 p.m. or the 9 p.m. or the 10 p.m. You have to maintain that time. Otherwise, you will find some time of the day or the night without this insulin. And if you use the insulin glargine 300, you will have a 3 hours flexibility. So within the 3 hours before or after the usual injection time. So that 3 hours flexibility is there with your 300 glargine insulin. But if you use this insulin deglutec and aspart, your flexibility time is much more and administered any major meal of the day. So because it acts beyond the 36 hours, maybe the 40 hours also. So today you can give it the 10 a.m. Tomorrow you can give it the 12 noon, or another day you can give it the 4 p.m. Another day you can give it the 10 p.m. because of the time flexibility. That is the biggest advantage of this combination of the insulin deglutec and aspart. So here the Research Society for the Study of the Diabetes in India say that it provides simple to administer, convenience of the one insulin and one pen, and requires the lesser dose. So here the basal plus and the insulin deglutec combination, it's a single drug. With the when the fellow is getting the basal bolus, that means the more shots of the prandial insulin, the basal insulin, you can give this injection as the BD also, morning and the night. So how to initiate the OD? Just to start with the 10 units of this combination with the most carbohydrate heavy meal of the day. So most of our people, they take lunch. So you can give it the 10 units before the lunch or 10 units before the dinner, and when you want the BD dosages. So this is also useful in elderly individuals because you can invite the lot of hypoglycemia in elderly individuals. This is less with hypoglycemia. With the renal impairment, again the renal impairment people, they cause a lot of the hypoglycemia. Again, this drug will not cause much hypoglycemia here. With hepatic impairment, so in hepatic impairment and renal impairment, usually we don't use the OHS, whereas the insulin is preferable, and this combination is much more preferable here. And during the religious fast, like your Ramjan, so where this drug is a long-acting drug, so you can give one shot before the Halim, along with the Halim, so that it will take care of the 24 hours time. And almost adult type 1 diabetes, so type 1 diabetes, they need multiple injections. So in the school going children, type 1 diabetes less than 10 years, around 10, 15 years, etc. You can give 2 shots of this drug. So to take care of the prandial and as well as the basal hyperglycemia. So thank you very much for your patient hearing. And if you have any questions, I will be very happy to answer.
Always we have to start with 10 units only, or if the person is severely diabetic, can increase the dose also.
You can increase the 10, not always with the 10 units, sir, but usually it's the 10 units. Suppose if the patient is obese, if the patient is also having other comorbidities, when the diabetes is very, the sugars are very high, you can start with 14 or 15 or 18 also.
Always OD dose.
Mostly it is a OD dose, but sometimes you can use as the BD dose also. But 80 to 90% you can use it as a OD dose. And it always depends on the carbohydrate content. Suppose if the fellow is getting the more of the lunch, you can give it OD only. At the night time, if they take the 1 or 2 snack, 1 or 2 polkas, etc., you need not give the regular insulin there. Suppose if the fellow is getting the 2 meals, very high calories diet with lunch and the dinner, then you can give the BD. But usually this drug is 80 to 95% as a OD only. Type 1 diabetes, sir? So preferably the type 1 diabetes, we prefer basal insulin as the insulin deglutide only at the bedtime, and the 3 shots of the regular insulin before the breakfast, before the lunch, and before the dinner. Because in the type 1 diabetes, usually they don't live for the longer period, because always the average HbA1c in them is almost beyond the 9 or the 10, most of our type 1 diabetics. So when you are living these people with the HbA1c of 9 or the 10, so definitely the nephropathy or cardiomyopathies or ischemic heart disease is very, very common when they achieve 30 plus or 40 plus. So most of these people, type 1 diabetes, when they get the type 1 diabetes at 15 or 20 years, they hardly live for about 40 or 45 years. So in such individuals, we have to keep the blood sugars very effectively around the 6.5 or 7, then they live for the 60 or 70 or 80. So to make them HbA1c at 6.5 or 7, so definitely we have to give the physiological way of controlling the blood sugar. So the most physiological way of controlling the blood sugars is give 1 shot of the regular insulin before the breakfast. That takes care of the post-breakfast hyperglycemia. Give 1 shot of the regular insulin before the lunch. That will take care of the post-lunch hyperglycemia. And again, the 1 shot of the regular insulin before the dinner, because these kids, they also take very high amount of the food at the dinner also. So give again a regular insulin before the dinner to take care of the post-dinner hyperglycemia, and give 1 shot of the basal insulin at 10 p.m. So that takes care of the basal hyperglycemia and fasting hyperglycemia. So it is very easy to say that we have to give the 3+1, that is the basal bolus therapy in the type 1 diabetics. But the kids, it's very, very difficult to address or to make them compliant with these 4 shots of the insulin. So in such situations, because of its to improve our compliance, so we always use the premix insulin. So 1 shot before the breakfast and 1 shot before the dinner, because most of these people are school going, or so it is very difficult to give them a before lunch prandial insulin. So we give 1 shot before the breakfast. So that includes both the regular insulin as well as long acting insulin, and again 1 shot before the dinner. But when you are using this premix insulin 2 shots a day, so their HbA1c is always beyond 7.5 or 8 or 9. So because most of the times we can't control the post lunch hyperglycemia. So in such individuals, always better to use these insulins. So otherwise you can make it as a 3 shots also. So 1 shot before the breakfast, 1 shot before the lunch, and 1 shot before the dinner. So that dinner this insulin will work for this. So by giving this insulin, deglutec and the aspart before the dinner, so the dinner postprandial hyperglycemia will take care of this your aspart, 30% the regular insulin, and the 70% of your deglutec will take care of the fasting hyperglycemia. So in that way, can you make them the 3 shots? See, in controlling the blood sugars in diabetes, most important is our dietary approach. So that is very, very important. So calorie restriction and more of the complex carbohydrates, more of the proteins. So definitely helps a lot to our diabetic patients. See, when you are using the analog insulins, the chances of getting the hypoglycemia are very, very less. Very, very less. Because when you are using your actrapid or your mixtures, etc., they are in the exomeric form and they have to be converted to the therapeutic action monomeric. It takes a minimum period of 30 to 45 minutes or hardly 1 hour also. So most of the time you have to maintain the time distance about the 30 minutes to the 45 minutes before the food and the injection. But practically most of our people know they take the injection and immediately within the 5 minutes they take the breakfast or the lunch. So your breakfast or the lunch or the dinner postprandial hyperglycemia will start within half an hour because most of our diets are the rice. So the rice will give you the postprandial hyperglycemia peak at about 1.5 hours or the 2 hours. So you are giving this regular insulin just before the food, and the action starts after 1 hour. And by the time the food is having the maximum hyperglycemia, so insulin is not working there. So you are not attacking the postprandial hyperglycemia with your regular insulins. So in such situations, if you use these analog insulins, they act within the 5 minutes. So when you are giving these analog insulins, when the patient is also taking the food, immediately it takes care of the postprandial hyperglycemia. And then postprandial hypoglycemia is also not there. So you have to maintain. So you have to proactive rather than the reactive. So when you are using the regular insulins, etc., you are reactive. But when you are using this analog insulins, you are proactive. You are attacking the postprandial hyperglycemia by using these analog insulins. Because this onset of the action is just 5 minutes. And the peak action is about 1 to 2 hours. And the maximum duration of the action is 3 to 4 hours. Whereas our regular insulins, the onset of the action is about 45 minutes to 1 hour. And the peak action is 2 to 3 hours. And the duration of the action is about 6 hours. So sometimes the people will get the hypoglycemia before the lunch or before the dinner. If you give the regular insulin before the breakfast, they will get the postprandial post-breakfast hyperglycemia, and then the pre-lunch they will have the hypoglycemia. So such things will not be. So compliance is very important. The only thing is cost factor here. So this injection is costing about 900 rupees to 1000 rupees. So it contains 300 units. Suppose if you are using the 10 units or the 15 units or 20 units, so that definitely have 15 days, 20 days. So I don't think that 15 days, 20 days therapy for 1000 rupees worthwhile, worth utilizing it. If you see the long-term complications. So you can keep the HbA1c around 6.57 very happily with these injections. So always for those people who can afford it. Now we have very, very good drugs in the diabetes. The only thing is compliance with the patient and the patient friendly management. These two will definitely help a lot. So thank you very much. Sorry.